Hello everyone, I'm Emily Jarmoloski and I'm going to be talking about the nursing concept of culture today. So, by the end of this presentation, we will be able to define what culture is, state how we're going to tailor our health assessments and physical assessments to someone's culture, and understand how culture is related to both the pathophysiology of diseases and pharmacology of diseases. We're also going to look at some evidence-based research related to culture, and we're going to learn how we're going to incorporate teaching of culture into nursing education and why it's so important to incorporate it. And in the end, we're going to do a reflection of our personal thoughts and opinions and how we can grow as nurses with our cultural competence. So first, let's do an overview of what culture is. This is a huge, complex topic. Giddens defines it as a pattern of shared attitudes, beliefs, definitions, norms, roles, and values that can occur among those who speak a particular language or live in a defined geographical area. So that's Giddens' definition, but it still doesn't encompass everything that a culture is. Culture is things you can see, like what somebody eats, how someone dresses, but then it's what you can't see, like the gender roles. It affects everything from a person's life, from the time they're conceived even till the time they die. It's what they eat, how they celebrate, how they dress, how they communicate, their religion, and just their everyday choices. And we have to keep in mind that just because someone speaks the same language or is born in the same place as another person does not mean they automatically will share that same exact culture. So, two things I want to talk about today that influence culture and can change someone's culture are technology and migration. Right now, we are so connected with technology, we can learn and communicate and interact with people from different cultures from all over the world. So that communication leads to a change in our culture and a change in their culture. And then migration, it's so easy for us to travel to different countries, different regions, even different states and cities, that we bring with us our own culture and leave an imprint on where we go, then also where we go leaves an imprint on our culture. So that is just a short overview of what culture is, some definitions, but there's still many more little intricacies that we could delve deeper into. So first, let's talk about how we tailor a health assessment to someone's culture. So it's expected of us that we do a culture assessment while doing that health history, that health assessment. One model that Kleinman suggests to use is the RESPECT model. It's an acronym that stands for respect, explain, social context, preferences and power, empathy, concerns, and trust. So we can use this model to kind of help guide questions that we're going to ask. Some questions you can ask is, what do you call this problem? What are you coming in for? It might have a different name in their culture than the American culture. How severe is this sickness to you? Do you think this will be a long-acting or a short-acting sickness? What kind of treatments do you think you need? What are some of the chief problems that this sickness has caused? And what do you think caused this problem? We'll get into it later, but different cultures will have different causes for the problems, and that's a good thing to investigate during the health history, that interview process. One other thing, we need to ask about someone's religion and health, because someone's religion might dictate some of the health practices. There's different practices in the death and dying process. Then also, one that gets brought up a lot is blood transfusions in religion. Last, while doing a history on someone's diet, the culture affects someone's diet greatly too. And then, while doing the health assessment, we need to keep in mind the power distance, it's called. So the power distance of someone's culture affects if they question authority, if they speak up, if they don't understand, and what do they do if they don't agree with the doctor. Maybe they're not going to speak up if they don't agree with your diagnosis. Maybe if they don't understand, they're not going to ask clarifying questions. So that's when you as a healthcare professional need to look for verbal cues of someone not maybe understanding or not agreeing, and kind of asking more questions and delving deeper into that problem. So last, something to keep in mind when you're doing a health history is, do you need an interpreter there, or do you need any text translated? So these are two terms that get confused a lot. Interpreter is spoken word. And then a translator works with written words, so papers and documents. But there's things that we need to think about when we're using interpreter or translator. There are some things that are very hard to translate. Sarcasm, jokes, and slang are some of them. So when you're working with a translator, try not to use these different phrases. One kind of funny slang that has come up in my clinical experience is a Spanish phrase that means I'm cold. So they say tengo frijol, which literally translates to I have been. So if that interpreter literally translated that sentence, the health provider would have no idea what it meant, and everybody would be confused. So just because someone is bilingual, they need to also understand the slang and medical terminology to be able to be an interpreter or translator. So moving on, how do we need to tailor our patient or physical assessment depending on the patient's culture? So there's always the modesty concerns. People have different reactions to pain. People might be more stoic. And vocabulary that we use, like we talked about before. So one example is how we need to tailor our assessment is while doing the stroke scale. I don't know if anyone has done the stroke scale previously with someone of a different culture or someone that speaks a different language, but it can prove to be very difficult. So the stroke scale is available in 11 different languages, but if someone can't read, how are they able to participate in it? Also, part of the stroke scale is asking them to repeat words or read sentences and describe what objects are and what's happening in the picture. So what if someone isn't able to describe maybe the cactus, or they've never seen a key that looked like that, so they aren't able to say that word? How, as a nurse, are you going to know if they have a loss of fluency or loss of comprehension or aren't able to name those pictures because they're having a stroke and that's one of the symptoms of a stroke? Or maybe it's just because part of their culture and part of their language is they don't have a word for that or they don't know what it is. So these are all things to keep in mind when you're doing that health history and patient assessment. Next, we'll move on to how pathophysiology and culture are interconnected. So different cultures will have different explanations for disease processes, and they might not understand or they might not accept the pathophysiology of a disease that we're explaining to them. Three major causes or ideas of causes of disease are biochemical, is what we use in our culture mostly. So that is bacteria, viruses, trauma that cause disease. There's a naturalistic view that looks more at the balance of energies, a holistic view of a person. And then there's the macro-religious view. So that's the supernatural world. It's like voodoo is an example of this. So on this next slide, we're kind of going to look at symptoms and different diseases and pathophysiologies that cultures use to explain the symptoms. So the first one is empacho. It's a term in Latin America, or a disease in Latin America. The symptoms are stomach cramping, stomach pain, and they explain it as a food ball stuck in the lining to the stomach. So a related term we might use here is an ileus. But also, there's so many things that could cause stomach pain and cramping. Maybe it's a gallbladder attack. So how would we as nurses explain to a patient that they're going to have surgery for what they thought was empacho, something that's usually not too big of a deal, but now they're having surgery for something that they don't understand and they don't think they need? Some of the other diseases are the lihi in the Philippines. So they believe something the pregnant mom eats in the first semester, or cravings they have, or things they think about will manifest in characteristics of their new child. One story states that the mom thought she ate too much crab meat, and that's why her children had claw hands or crab hands, the technical term ectrodactyly. She didn't understand that this was a genetic condition. She thought, it was kind of this supernatural, natural thing, and it was her fault for eating too much crab. And how would we explain this to a patient? And then also there's the Shen Kui and the Chinese and Hawa Tik and the Native American population. So these are two diseases that we don't have here in all culture that at least the Chinese disease Shenqi, they think it's a very life-threatening disease. They have symptoms of anxiety, backache, dizziness, weakness, and they might be having a heart attack. But they think that all these symptoms are caused by excessive semen loss. So how do we explain that to the patient? Then bringing it back to the interpreting side, how would an interpreter translate empacho to English when we don't have a word for it? So there's no literal translation, so there's a lot of things that make it difficult for healthcare providers to take care of people of different cultures. So next, we'll move on to pharmacology, pharmacotherapeutics. Different cultures will use different medicines and different therapies for different diseases. They might use emollients, herbs, foods. We have to think about the interactions that these traditional medicines will have, what their efficacy is. Are they working? Are they not working? Are they actually causing harm to the patient? And then who are dispensing these medications to our patients? Is it a religious leader? Is it a shaman, curandero? Boucher is kind of the traditional healer in the Amish culture. But then also in many cultures, moms and grandmas are thought of as that healer. You go to them when you get sick. So now that we kind of talked about the 3 Ps, I'm going to move on and start talking about theories that relate to cultural care. So there's Leininger's theory of cultural care, diversity, and universality. Her model is called the Sunrise Model, which you can see to the right-hand side of the screen. And it mainly has 2 things that it states. You need to understand your own culture before you understand other cultures, and that all human behavior is guided by their culture. Next, I want to explore a research paper or concept that will help us as nursing educators prepare nursing students to be culturally competent. So this study followed BSN students in Hawaii. They took a dedicated transcultural nursing class, and before and after this class, they took a survey to kind of gauge how their cultural competence had changed. So the results showed that their cultural awareness level increased. They thought that clinical experiences were the best way that they learned about cultures, but still, even after taking a dedicated semester-long class, they were not confident or comfortable taking care of people of different cultures. They were more comfortable in the beginning, but still not 100% confident. And they also stated they wanted more practice using interpreters, and that's one thing that they did not feel like they improved on after taking this course. So for us as educators, these are all good things to keep in mind when we are teaching culture. So why do we need to teach culture? Why is it important? The National League of Nursing states it's part of beliefs and values as nurse educators that we need to integrate cultural care, cultural competence into nursing curriculum, both globally and locally. So we have to look at our local culture and the global culture. We're not able to be very empathetic for other cultures if we don't understand that culture. And cultural competence is expected of our ends. We just can't treat everyone like they're from the same culture. And then if we look at the population of the United States, we're very diverse by race, ethnicity, place of birth. And by 2050, 50% of our nation will identify as coming from one of these racial or ethnic minorities like Hispanic, African American, Asian, or Native American. And you can see right now that a little bit less than half identify as a minority. So the cultural mix of the U.S. is going to be changing. So now that we know it's important to teach culture, how do we do it? We need to build a desire in our students to learn. We need to teach them how to be self-aware of their own culture and then build their knowledge and skill set. To do that, we can combine both classroom learning, lectures like this, simulation labs, and then clinical experience in the community with people of different cultures. One way to integrate cultural learning into the simulation lab is to have the different nursing students investigate different cultures. They can learn about their food, language, customs, modesty, family dynamics, who is the decision maker in any traditional medicine practices. And then once they got this, all the information down, they can practice interviewing one another and learning about the different cultures. One other way to kind of teach culture to the nursing students is I would like to do what we did in previous weeks and integrate real life patient stories like that of Lewis and the Toradol issue. So this next slide, I'm going to give a little overview of a real life situation. So when you look at this word intoxicado, you probably think of intoxicated either by drugs or alcohol. And that's what happened in this situation. So Willie Ramirez was a Cuban teenager living in the United States. He ate at Wendy's for the first time and then went to work on a car. He got a headache, went unconscious, family brought him to the ER. And while the doctor was interviewing the family with an interpreter, the family said the word intoxicado. So in the Cuban culture, intoxicado does not translate directly to our word of intoxicated. It means that maybe they're intoxicated by eating bad food. Maybe they had chemicals from working on the car. So when the family used this word, they weren't implying that they thought their son had taken any alcohol or drugs, but because of the doctor's culture, he assumed that the family thought that their son had taken drugs or alcohol, so that's what they wrote off as the diagnosis for this patient. Then it was 2 days later, when the patient wasn't getting better, they did a CAT scan that showed a bleed in the brain. So by this time, the patient was a quadriplegic and has many lifelong problems just because of this one word that was misinterpreted between the doctor and family. And because of the family's culture, they didn't feel like they were able to speak up and disagree with a doctor when the doctor said that they're getting admitted for, drug overdose or alcohol overdose. So this just shows the importance of being culturally competent and the consequences of that breakdown in the cultural competency. So to finish, I wanted to move on to a self-reflection. So we all need to kind of do a self-reflection on how we can improve our own cultural competence. And like with the students, we all have to start with that desire to learn about our own culture and other cultures. And then, like Leininger says, we need to be aware of our own culture before we are able to learn about other cultures. We also need to be aware of how our own cultural beliefs carry over to our professional career. Maybe we take care of people differently depending on what their culture is and what ours is. After we build that awareness of our own culture, we can move on to getting that knowledge and skills of other cultures. Some ways that it is suggested by Jarvis to build that knowledge is to expose yourself to other cultures. Not just by reading books. So you can try different foods, maybe learn a new language, visit grocery stores, go to festivals or parades, and make new friends of different cultures. Do a kind of combination of everything to learn about the different cultures. And then it's not a set skill. You need to continuously improve it, continuously strive to learn more about different cultures. So, in conclusion, today we have learned that culture is very complex and everybody has their own unique mixture. We need to tailor health assessments and physical assessments to a patient's culture, and that pathophysiology and pharmacology are interconnected with someone's culture. We learned about Leininger's theory of cultural care, how we need to know our own culture before we can learn about others. Learn why and how to teach culture to nursing students. And then I urge everyone today to do kind of self-reflection about their own culture to kind of help them get on that path to start broadening their horizons and learning about different cultures. Thank you for listening to my presentation, and I hope you found it very informative.